And today, coming back with the Impressing Your Attending series, my name is Jonathan Munoz, and I'm going to talk to you about the progress notes today. This is very important. Hopefully, you get to catch your attending's attention with this scheme that I have. Okay, so I just want to say that these progress note formats and the HMP that I did before are meant for inpatient use only, not outpatient clinic. The clinic's way to do notes or assessments is different. So, okay, so for the progress note, the sub format is still in use, subjective, objective, assessment, and plan. Um, it's not the same. Don't expect that when you open a chart from that was written by an attending to have the same that I'm going to describe now, because attendings at when they're independent, they document more succinct and more to the point. They sometimes they don't really explain their thoughts on their notes, and that's fine because they're able to follow up their own notes. But you have to be able to communicate your thoughts and the way you are um, processing the information that a patient is giving you in front of an attending and give your reasoning there. Okay, so still in use. The S is stuff that happened after you left. So the subjective part should be able to bring your attending up to speed on what happened since he left yesterday at around noon after finishing rounding till today in the morning when he's rounding again with you. So you have to bring him up to speed. You have to say, this happened overnight. He was seen by these people. He had a CT scan. He had an MRI. He had a cardiac arrest and was transferred to the ICU. And and then today he is eating fine. He's ambulating. He's pooping. All that stuff. Um, so let's move to objective. Do not give any explanations in this part or in the on the subjective part. Just give report, no explanations. You don't have to give any assessments yet. Provide ranges for all your vital signs, at least 5 to 7 systems for physical exam, and only the pertinence. But remember to type down at least 5 or 7 systems, but you only report the pertinence. An assessment plan, the same, follow the same structure and give the problem number one, which is the most um, dangerous problem, the one that's going to kill the patient. Give me a possible etiology. Give me a status of the problem. What is your proposed workup for the day, and what is your treatment plan? Because remember, if you are keeping a patient in the hospital, there must be a reason. So let's say CHF exacerbation, likely due to medication non-compliance. That's the etiology. The status, improve from yesterday or worsening from yesterday. Workup for today, pending echocardiogram report and cardiology consultation. Treatment plan, continue Lasix IV TID, continue telemetry, continue electrolyte replacement, and monitor eyes and nose. And if a problem resolved, then say that it is resolved. Like say you're following a patient that had AKI yesterday, but today with fluid hydration, he's no longer on AKI. So you say AKI likely due to dehydration, resolved. Condition is resolved. So you don't have to do any more workup or anything. And then in inpatient care inside the hospital, whether you're rounding with family practice or inpatient internist teams, your thinking should be when you see a patient and when you treat a patient is, what am I doing today to safely discharge this patient home tomorrow? So what are you doing today? Are you changing IV antibiotics, IV therapies that are no longer used or needed to oral options? Or are you discontinuing the vasopressor support that this patient is? Or are you decreasing the oxygen supplementation that this patient is getting from 6 now to 2 liters, and you're going to try to wean him off today? How are you going to discharge this patient? Are you following on his physical therapy evaluation? Now, this part is important. Um, Fixing the problem that the patient had is one thing, but fixing the collateral damage that this patient problem caused to his body is the second part of the treatment plan. So many patients that get hit by sepsis, CHF, pneumonias got deconditioned. They were able to walk independently before the problem, but now they are below their baseline. They are not able to walk or stand because they're very weak. So they are not able to fully be safe at home on their own. So you have to either send them to a nursing home, provide physical therapy options at home. If they have the right amount of support at home, then it is possible, but you have to think about that. Then the other problem that is going to make you look good if you always take care of it is that you mentioned that the home medications were reconciled. Many times a patient goes 3 to 5 days without having his home medications reconciled, therefore he's not taking them in the hospital. For example, let's say you're admitting a patient that has appendicitis, but he also has rheumatoid arthritis and he takes prednisone 20 milligrams once a day for the last 3 years. But you admit him, and for 3 days he hasn't taken any prednisone and he's feeling terrible, he's vomiting now, and you're concerned and you don't know what's happening. What's happening is that you didn't put him back on his home medications. All right, so another thing that you have to keep in mind when doing inpatient rotations is the list. There is a list that you will be given every day, or you are able to print every day if a patient is assigned to you, and it will have the names of the patients that you are given. So, for example, this is my list for today. I have 4 patients that I have to see, and I create this list. You will have to create your own list saying, okay, for John Doe, reminders, right? This is your brain. This is a 27-year-old admitted for acute appendicitis on Solsin day 3, post-lab API on a clear liquid diet. Same for cookie dough, same for taekwondo, and same for weirdo. You have to have reminders of what's going on. Why? Because let's say you're attending calls you later. Hey, Munoz, what's going on with cookie dough? Um, is he still on flagell? And if you have 10 patients, you're not going to remember what's going on with cookie dough. So you open your brain and say, oh yeah, he's on Cipro on day 4. Okay. And then, okay, change him to PO. So then you have to update this list instead of IV, flagell Cipro PO now. See, little things are going to happen and you have to update your list. So you have, now that you are working on one patient, you have to update the list, you have to prepare your progress note, and you have to take care of the patient. And the other thing is that this list is that you have to keep it at hand and always with you during table rounds, because during table rounds, you're attending. It is the common way that we have been doing table rounds for years, that when we present the case to the patient, to the attending will be like, okay, could you order a CT scan for this patient? Could you order a BNP for tomorrow? Could you discharge this patient? So those are your chores for the day. Um, those are the scat work that you're going to have to do today, because your attending wants it, because it's overall this patient is under his care, so he wants whatever he wants, you have to get it done. And so at the end of the presentation of your patient, your attending will give you little things to add, or he will be mentioning during your presentation. So you have to try to write them down like this. So for example, for John Doe, this is today pain meds for home, and follow-up diet tolerance for this other one, surgery consult, and so. And as you go completing these chores, you have to check them out. So don't forget, it's a common way that we used to do it. And then this that you're doing today, you have to update on your progress note and on your list. So that way, if someone asks you, you know what to do, what you're doing, what happened today, just by looking at your patient list. All right. So let's do our case, the CHF case that we had on the HMP. So we already admitted the CHF case. You can go back to that HMP. So now I'm gonna work on his progress note. This is day number 2. He was admitted with respiratory failure and was put on IV Lasix. Now this is day number 2. So let's see what happened. Follow up on CHF exacerbation. Patient was seen yesterday by cardiologist. Recommended to continue carvedilol and Lasix at the same dose. Echo is still pending, and cardiologist reports that he may need cardiac catheterization to determine cardiac anatomy due to presenting symptoms. His 24-hour urinary output is 3 liters negative. He reports improvement in shortness of breath, now on 2 liters, oxygen supplementation from 6 liters. No acute events overnight, tolerating diet. He did work with PT today and was able only to walk 5 steps, which is below his baseline. Alright, so subjective is done. Objective, respiratory rate from 50 to 20, heart rate 70 to 85, BP 110 to 135, systolic and diastolic 45 to 70, O2 94% on 2 liters, and urinary output 3 liters negative. Constitutional, no acute distress, crackles, no cardiovascular, regular rate and rhythm, no murmurs, bilateral lower extremity edema, 1 plus from 2 plus yesterday, no JVD, respiratory crackles bilaterally, no wheezing, abdomen soft, non-tender bowel sounds positive. You can skip the rest because, or you can say rest of the physical exam is within normal limits. And labs, unremarkable except for sodium 139 from 132, potassium 3.8 from 4.8, creatinine 1.1 from 1.6. Why I mentioned those? Because those are ones that in the HMP were abnormal. And I can say the rest of the blood work is within normal ranges. Okay, this assessment and plan. Male patient, 75-year-old, admitted for shortness of breath, found to have elevated BNP and chest rate with bilateral infiltrate. You can add admitted for CHF exacerbation or respiratory failure. Okay, problem number 1 is acute hypoxic respiratory failure due to acute diastolic CHF exacerbation. Condition is improved. Urine output is 3 liters negative, less edema. O2 on 2 liters from 6 liters. Workup pending echocardiogram. Report and possible cardiac catheterization. Treatment plan day 3 hospitalization. Continuing telemetry. Change IV Lasix 40 milligrams from TID to BID. Continue oxygen supplementation. And the attendant said maybe Munoz, get a BNP for tomorrow. So then I will, on my paper, on my list, I will write, BNP for tomorrow morning. So I have to order it on the records. Okay, next problem, atrial fibrillation with RVR improved, now rate control and back to sinus rhythm. Workup, same as number 1, treatment plan, tolerating low dose carvedilol will increase as tolerated, and possible anticoagulation with Eliquis after catheterization. Next problem is AKI due to volume depletion, improved, continue diuresis, monitor renal function. Yo te dice, Munoz, order a BNP for tomorrow. Check the creatinine tomorrow. So I have to write it down so he knows I'm paying attention and I'm doing what he's saying, and give him peace of mind because I'm writing it down so it's less likely for me to forget. Next problem, hyponatremia, resolved. Hyperkalemia, resolved. Deconditioning, new problem. Patient was unable to ambulate more than 5 feet. This is below his baseline. And the treatment plan is PT evaluation and possible need for a sniff placement at discharge. We will discuss this with the case manager. So that's it. That's the progress note. And if you do it this way, you will do fine. This is the way that we like residents, interns to do their notes. And this is one of the problems that we encounter the most with international medical graduates. They know what to do. I mean, they know what they are doing, the management they are doing, but their style is not the same as the most of the American schools students. So let's see if you can try to imitate this style, and if you like it, great. I really think that it will help your rotation. So next one is the discharge summary. So stay tuned for that one. Thank you.